Esophagomyotomy, Heller type, abdominal approach. Thoracic approach. The esophagus is repaired using a fundic flap. The physician accesses the esophagus through an upper abdominal or a thoracic incision. For an abdominal approach, report 43,330. For a thoracic approach, report 43,331. The physician makes an incision into the muscular layers of the distal esophagus and cardia of the stomach, myotomy, leaving a gastric fundic flap. The flap is pulled along the esophagus, and sutured onto the margins of the myotomy. Repair of a hiatal hernia is performed by restoring the herniated portion of the stomach back to the abdomen, then narrowing the hiatal opening of the diaphragm by suturing the left and right crura together. All incisions are sutured in layers. Repair, para-esophageal hiatal hernia, including fundoplication, via laparotomy, except neonatal, without implantation of mesh or other prosthesis. With implantation of mesh or other prosthesis. Repair, para-esophageal hiatal hernia, including fundoplication, via thoracotomy, except neonatal, without implantation of mesh or other prosthesis. With implantation of mesh or other prosthesis. Repair, para-esophageal hiatal hernia, including fundoplication, via thoracoabdominal incision, except neonatal, without implantation of mesh or other prosthesis. With implantation of mesh or other prosthesis. Esophageal lengthening procedure, e.g., collis gastroplasty or wedge gastroplasty. Esophagojejunostomy, without total gastrectomy, abdominal approach. Thoracic approach. The physician removes the affected esophagus and stomach, using the remaining stomach and jejunum to restore gastrointestinal continuity. The physician accesses the esophagus and stomach through an upper abdominal or a thoracic incision. For an abdominal approach, report 43,340. For a thoracic approach, report 43,341. The physician resects the affected part of the esophagus. The stomach is advanced through the hiatus and sutured to the esophageal remnant. The antral portion of the stomach is excised, and the proximal jejunum is sutured to the gastric remnant. The distal end of the duodenum is anastomosed to the jejunum, the proximal end of the duodenum is sutured closed to form a blind pouch. The incision is sutured in layers. Esophagostomy, fistulization of esophagus, external, thoracic approach. Cervical approach. The physician connects the esophagus to the exterior of the body, creating a fistula for drainage. In 43,350, the physician makes an upper midline abdominal incision to access the esophagus. In 43,351, the physician uses a lateral thoracotomy to access the esophagus. In 43,352, access is gained through a cervical incision. The physician makes an incision in the esophagus, or uses the esophageal stump as an opening. The proximal limb of the esophagus is exteriorized and sutured into place, creating a connection from the exterior of the body to the esophageal lumen for mucus drainage. The incision is sutured in layers.